I'm Laurie Berard, and I'm here again with Dr. Pratik Choudhary from King's College Hospital in London, UK. Let's talk a little bit about insulin pump delivery systems. Again, individuals coming into hospital, coming in with these devices. What does the provider looking after them need to know about insulin pumps?
Sure. So I think as pump therapy is growing internationally, more and more people are going to end up coming into hospital on these devices. In the US, maybe 40% of people with type 1 diabetes use a pump, and across Europe, the number varies between 20 and 40%.
Do we ever see it in type 2?
And and so in certain countries, it's funded in type 2 diabetes as well.
Mm-hmm. If someone came in, it doesn't necessarily mean 100% that they have type 1. Yeah. So we shouldn't make that assumption. That's a really important point, Laurie. Yeah. Thanks for bringing that up. That actually, it's just a way of delivering insulin that makes it convenient and delivers it in a better way. Mm-hmm. And so for our listeners who may not be familiar, may not have seen a pump, so a pump is a small device, generally with a battery, and it will be filled with a certain amount of insulin that the patient will change, usually every 3 days. So it has about 3 days worth of insulin. And then instead of taking multiple injections through the day, the patient has a pre-programmed level of basal insulin. So instead of their background insulin, such as maybe, you might have a patient who's on 20 units of Lantus, for example, instead of giving 20 units of Lantus, it will give 0.8 units per hour over the 24 hours. Okay. And that level can be varied through the day, as you know. And then whenever they need an extra dose of insulin, a bolus dose of quick acting, they will take they can press a button and get the quick acting insulin. And that makes it much easier for those people to take the extra insulin and take repeated boluses, and also more precise as well. So I heard a couple things. Every 3 days you're changing. So you're changing the cartridge typically and the infusion site. Yes. So that's best practice. The other thing I heard you say is that the pump is really about basal insulin. It's the being able to get the best basal insulin for someone. Although people living with diabetes, they're very attracted to the pump system because they no longer have to poke. Yeah. And so they can give insulin whenever they want, as often as they want. And so they're often more excited about the bolus part of it. But as a healthcare professional, we're really looking at getting the basal right.
I'd say both. I'd say both are important. So you can adjust the basal according to your kind of day and night, and if you're exercising, you can cut it down. But absolutely, one of the advantages that people on pumps do more boluses on the whole than people on injections, and they can be more precise and specific with their boluses, and there's some advanced features of how the bolus is delivered that they can go into as well.
So they need some support around that, but typically that would mean that individual that's on the pump that has all those extra settings is being supported by someone like yourself, a diabetologist.
Yeah, most often, usually people on a pump will have had a lot of education around carbohydrate counting. They'll be set up, they'll be generally on the whole seen in a specialist center. And so that means they should be quite knowledgeable about their pump. But again,
sometimes that doesn't happen.
Sometimes that doesn't happen. And I think when they're in hospital, of course, what we have to recognize is that if they're on a pump, they need to have supplies. Because of course the pump, they need to change the pump. And to pick up on something you said, that pump is usually, for the vast majority of pumps, connected to the skin via cannula. There are some manufacturers out there, and in the next few years we might see some more, where that tubing doesn't exist and the pump is just a small device that's just stuck to the skin, often on the arm or on the stomach. So.
Yeah. And I'm from North America versus the UK, and so we are seeing a lot more of the wireless pumps that have been, the tubeless pumps that have been uptaked in North America just based on access there. And I'm sure that's something obviously people living with diabetes are excited to not be necessarily connected to the tubing. But that takes us to another issue around the pumps. They sound great in terms of how they deliver and how they can be all calculated. Is there risks of being on insulin pump therapy that people should be aware of that might cause someone to come into hospital, for example?
So I think you're picking up on a point. So the commonest reason for someone on pump to be admitted to hospital is if the pump fails, or more importantly, sometimes that cannula, that tubing can get blocked up, and the person thinks they're getting the insulin, but actually they're not, and glucose levels rise, and that can lead to ketoacidosis. And actually that's more common in the first few years or first few months on a pump when people are getting used to it, but can still happen ongoing. And every now and again we get people coming into our hospital as well. We've got a big pump service where they've been unwell, they've been on a pump, maybe that cannula didn't go in or got kinked, and they didn't get the insulin they thought they were getting, and they run into DK as a result of a insulin delivery failure, not because they weren't taking their injections, but because the pump wasn't delivering the insulin.
So that is a reason that they might be driven to hospital. So great troubleshooting for the admitting physician. Your hyperglycemic blood sugars are high, maybe you've got a bit of ketones going on. So just sometimes it's as simple as looking at the delivery device.
And checking the pump,
And checking the pump. So in a previous discussion that you and I had, we talked also about continuous glucose monitoring systems and recognizing that some insulin pumps now also have integrated continuous glucose monitoring systems. Can you describe what that benefit is for people with diabetes?
So I think that's a really key step, and we're just on the threshold of this kind of new revolution, if you like, of people who can use the pump, which is going to deliver the insulin, and then the pump can have an algorithm or a system or a brain, if you like, that then can take data from a continuous glucose sensor, something that measures the glucose all the time, and then automatically decide how much insulin to give. And most importantly, it's like overnight, it can increase or decrease the amount of insulin depending what the glucose is. And what we're seeing coming back, and there are over 100,000 users of these systems now in the US, that patients' glucose levels are really, really well controlled. They get really reliant on these systems. And of course, if someone like that comes into hospital, we have to be aware that they need both parts of that system to be working properly. The pump has to work and the sensor has to work and has to be working correctly. And then in hospital, we have to be aware that, if there's a problem with there, that how we recover from that and how we manage the insulin delivery, which the patient might actually have become a bit complacent sometimes if they're reliant on this technology. If the technology doesn't quite do what it's supposed to do, that can cause problems as well. So if you see someone with both those devices, it's important to work out what they do and understand that if they're working correctly, yes, great. If not, then how do you take over control back from the machine, if you like, in that hospital setting?
So I think what you're also saying is that the individual who's admitted to hospital, who's using pump therapy,
whatever technology,
if they can, let them do their thing, but make sure that they haven't become complacent. So it doesn't necessarily mean that this person's 100% bang on with what they're doing. So maybe take a look at that. But if you can, allow them to self-manage. And if in fact they happen to come in with both systems, again, same idea. But if it's for a reason that allows them, they're admitted for anything other than perhaps they're in DKA, severely hyperglycemic, don't need interventions outside of their own therapy, that the opportunity to allow them to have both systems working could actually probably change their course in hospital because their glucose control will be comfortable for them because they know what's happening and they can use some support from someone to just tweak it a bit to get to where they need to be.
If they need to, absolutely. And as you say, it depends on the reason they're coming in. And if they're coming in because they're for a routine procedure where actually they're quite compos mentis and everything is going smoothly, I think these devices can manage the glucose far better than we can. But if they're unwell and their physical situation is quite different, they've got an illness maybe that can affect the way glucose works, kidney failure, liver problems, and that's a scenario when I think you might want to get a specialist in if you're not quite sure what's going on.